ladies and gentlemen. Thank you for coming. I think this conference gets better and better every year. It's very nice to see the familiar faces, always nice to see new faces. And I think the best part about this conference is that sometimes after talking to my colleagues and listening to presentations, I end up leaving home with more questions than answers. And that kind of keeps the brain going. So today I wanted to talk about nutritional considerations of high volume liposuction in patients with lipedema. No disclosures. As plastic surgeons, and I've been a plastic surgeon for over 20 years, I can tell you that as a part of our plastic surgery training, we get a lot of training in liposuction. However, nothing in my plastic surgery training prepared me for treating patients with lipedema. And it has to do anything from basic of technique, to equipment, to solutions that we use, to considerations on systemic body effects, and definitely we did not talk about the effects of nutrition, protein, risk factors that are specifically relevant to the patient with high volume liposuction with lipedema and associated conditions. As we consider traditionally, the low volume liposuction is under 5 liters. The 10 liters, 5 to 10 liters is a high volume, and finally mega volume liposuction is over 10 liters. My practice traditionally focused on patients with higher volumes because we're trying to lower the number of surgeries, and that's where most of the time I perform either the high volume or low volume, or mega volume liposuction. And as there are no official guidelines, we're all trying to push the envelope a little bit, eventually making mistakes, returning back, and learning from our own experiences and experiences of our colleagues. This is very typical of patients that I see. For many of the patients, we're the last resort. A lot of them are at the stage when they're just about to hit the wheelchair. Again, majority of current protocols and insurance policies unfortunately deny these patients the procedures that they require. We do not limit our patients with BMI. The highest patient that we treated had BMI of 69. Our goal is to provide the care to the patients that are able to heal, and we have completely different set of internal guidelines to make sure that we're able to help those patients, because otherwise nobody will touch them. I perform currently right now slightly over 100 high volume liposuction procedures per year. So the results of today's presentation is pretty much our own observations. I've been reviewing the literature on the high volume liposuction, and we can see that the number of high volume liposuctions increased significantly over the last several years. So now we started looking at things that we never looked in cosmetic patients: fluid shifts, electrolyte balances, cardiac issues, renal issues, and finally nutritional ones. The main parameters, and I'm sure most of you are aware, strict fluid control, monitoring fluids going in and out, making sure there's no fluid overload. We all taught about minding the lidocaine toxicity, and the traditional benchmark is about 35 milligrams per kilogram. What we never spoke is about the effect of high volume infiltration solution on kidneys, because usually in cosmetic liposuction, when we inject liter or 2 liters, it really does not translate in significant changes in the kidneys. But with putting 8 or 10 liters of tumescent solution, epinephrine does have significantly profound effect on renal flow. So we monitor renal flow, renal function, glomerular filtration rate, creatinine, and BUN. There is a study that I came across several years ago that looked at the drop of hemoglobin in patients with high volume liposuction. What they suggested that for every 2 liters of liposuction aspirate, the total aspirate, the hemoglobin usually drops by 1 point. It does not necessarily happen in low volume liposuction patients, but this has been our guideline provide safe high-volume liposuction procedure and limit or decrease the amount of patients undergoing blood transfusions after the surgery. So for example, if hemoglobin is 13 and we remove 12 liters, we expect a drop of hemoglobin down to 8 or 9. Again, transfusion level is 7 usually with systemic symptoms. This is pretty much says the same thing, but I want to slide down to the middle of the page, and I wanted to talk about things that we didn't talk before, which is pre-albumin and albumin. And traditionally, we talk about protein supplementation as important factor in healing the liposuction patient from the standpoint of building blocks of scar tissue. But I think in a high-volume liposuction patient, we also have to look at the role of the intravascular protein and its effect on oncotic pressure. So for those of you who are not fully ingrained in medicine, the protein that floats in the bloodstream has a holding pressure to the liquid. So in essence, if you take the protein out of the bloodstream, the liquid, the serous, the watery part of the blood will leak out through the blood vessels. So that oncotic pressure is kind of holding pressure that protein has on the liquid, keeping the fluid inside of the bloodstream. What we have noticed is that with the drop of pre-albumin, albumin, and other proteins, the oncotic pressure drops. What happens is that the fluid, the liquid part of the blood, goes into the tissues where the surgery was performed, like in the legs, arms, and torso. So effectively, patients had received a lot of fluid. They're actually overloaded with fluid, all that fluid in a third space, in a subcutaneous space. But inside of the blood vessels, they're effectively dehydrated. So, and this represents a challenge. What do you treat them with? Do you treat them with diuretics, or do you actually load them with fluids more? And because they do not have high oncotic pressure, the fluid will effectively get in the bloodstream and go third space in the subcutaneous tissues. And the rest of the items on this menu is pretty much standard. We check anticoagulation, avoid aspirin, Motrin, ginger, garlic, avoid surgeries during the menstrual periods. We do administer TXA, 1,000 milligrams before and after. We do it in IV fashion. My personal experience, we tried it in the tumescent solution. The bodies get infiltrated in the tissues, but it did not provide the same effect. And we universally provide patients with DVT prophylaxis. All right, so what we did over the last several months, we started checking all the patients and looking at what happens with their protein levels while they are in a hospital or while they're in the area. And what we found that in majority of these patients, they experience between 35 and 50% drop in proteins over the first week after the surgery. And that kind of explains the postoperative hypotension. It explains significant swelling in the lower extremities or the other operated areas. And it's challenging to treat them because, again, you try to improve their dehydration, but all that fluid that we put in, especially if it's not supplemented with electrolytes, goes to third space. So our solution has been, first of all, we significantly increase preoperative protein. And I know traditionally people recommend doing 1 gram of protein per kilogram of ideal weight or dry weight. I think, a dry weight. What we do, we ask the patient to double it up. So we ask them to take 1 gram of protein per pound of their dry weight. So in essence, we ask them to take close to 80 or 90 grams of protein a day. This is challenging. For most patients, it's challenging. We start about 3 weeks after the surgery. Before the surgery, hoping that the drop will not be as significant and impactful to the intravascular issues. The other thing we find is that appropriate compression, and we like JUZOs, it significantly reduces swelling if patient gets proper compression, and we compress the patients all the way from the feet all the way to the groin. And we find that that kind of controls both the bleeding and third spacing. And finally, I want to talk a couple of minutes about vitamin D. There was an interesting article published. They looked at the levels of vitamin D preoperatively and then postoperatively. And what they found is that there's a profound drop of the level of vitamin D after the surgery. And as you know, the vitamin D significantly impacts majority of the processes, and it directly correlates with level of pain and postoperative discomfort, with the levels of inflammation. And because vitamin D is also intimately related to the metabolism of fatty tissues, obviously it's expected that the level would drop. So again, preoperatively and immediately postoperatively, we recommend improved or increased dose of vitamin D supplementation. The question is that the dosing of supplementation is not clear. A lot of people feel that vitamin D cannot be absorbed in more than 5 to 10,000 units per day, even though some doctors administer up to 50,000 units per dose. I don't have the answer, but we try to get the patient to maximize vitamin D intake. As we were doing more and more surgeries and becoming more and more aggressive, it became apparent in our personal experience, as well as in the study that actually came out incidentally at the end of the 2024, that one of the biggest predictors of complications of high-volume liposuction surgery and lipedema patients is preoperative anemia. And a lot of times it goes undiagnosed because a lot of patients have higher than expected or anticipated levels of hemoglobin because they're constantly dehydrated. And once you rehydrate them, they're actually anemic. So I think we need to have a deeper dive before these surgeries into the iron binding capacity, transferrin, and we're not ready to provide any kind of recommendations from the standpoint of guidance on iron supplementation. We're looking into that, but I can tell you that in our experience is any patient who is borderline anemic with a hemoglobin of 12, at this point we most likely will not do the surgery because of significantly higher risk of complications. Again, one of the other things that we recommend, obviously, to make sure that for safety, you have properly accredited facilities. I'm not going to go into the rest of the effects. I think I'm a little bit close to out of time. But overall, from the standpoint of pre- and post-operative management, I would strongly suggest looking into protein levels, supplementation before the surgery, improving vitamin D, and really carefully monitoring and evaluating subtle or subclinical anemia. Possibly you need to see a hematology specialist, especially if you have underlying metabolic disorders, and a lot of patients with lipedema unfortunately do. Thank you.
We do have time for a question.
I'm sorry?
We do have time for a question.
Oh, perfect.
Yes. Is preoperative protein more important than postoperative?
I'm sorry?
Is preoperative protein more important than postoperative?
They're both very important, but here's a dilemma. Whenever the patient undergoes a surgery, patient experience change in a perfusion, we believe, of the internal organs because significant portion of the perfusion is directed to the peripheral tissues that are healing. And as such, I do not believe that the rate of absorption of proteins in the immediate post-operative period is as good as before the surgery. We don't have the data or ability to study it. Hopefully the foundation has the funds and ability to do it. But we strongly recommend patients not relying only on traditional nutritional sources, but actually getting the protein shakes. I know a lot of people don't like protein shakes, but for the immediate perioperative period, meaning before and after, I think it can significantly reduce swelling, decrease the risk of complications, and overall facilitate the recovery.
Okay, thank you.
Thank you.